I'm Monty Mython, Editor-in-Chief of Top Med Talk. Welcome to Journal Club.
Top Med Talk.
So, welcome to Journal Club Express. Me, Monty Mython, Editor-in-Chief of Top Med Talk. In Journal Club Express, we don't take a deep dive into the paper, but rather just highlight some of the recent publications that may be of interest to you. This week I've chosen a publication from the Journal of Clinical Anesthesia, Volume 55, August 2019, pages 83 to 91, and all the links through PubMed are in the show notes. It's entitled The Effects of Dexamethasone, Light Anesthesia and Tight Glucose Control on Postoperative Fatigue and Quality of Life After Major Non-Cardiac Surgery, a Randomized Trial. First author is Bassem B. Abdelmalak. Senior author is Daniel Sessler from the Cleveland Clinic. Now, the question that they're trying to answer is whether you can influence postoperative inflammation and therefore have a positive impact on postoperative fatigue and quality of life. Now, it's rational. We know that surgery produces a strong inflammatory response. We know people get fatigued. We know the quality of life can be reduced, and we believe they're linked. So this study explored three potential anti-inflammatory interventions: steroid administration, tight intraoperative blood glucose control, and light anesthesia. It's a randomized trial. The setting was the operating room and the postoperative recovery areas, the ICU, the hospital floors or wards. The patients studied were patients undergoing major non-cardiac surgery. It's a complex trial design. The patients were randomized to perioperative intravenous dexamethasone, a total of 14 milligrams tapered over 3 days versus placebo. Intensive versus conventional glucose control with a target of 80 to 110 versus 180 to 200 milligrams per deciliter, and light versus deep anesthesia, judged by the bispectral target index of 55 versus 35 in a three-way factorial design. Now, if you really want to get into this paper and you're interested in trial design, factorial designs are where you can multiply randomize people and then pick from the various different groups of interventions and control groups, and therefore increase your total number in each group to see if there's any hint of an answer. Measurements. In this planned sub-analysis, quality of life was measured using the SF12 preoperatively and on postoperative day 30. Postoperative fatigue was measured using the Christensen Visual Analog Scale, both preoperatively and on postoperative day 1 and day 3. They assessed the effect of each intervention on fatigue and on the physical and mental components of the SF12 summary scores, and they used repeated measures linear regression models. Main results. 362 patients with complete data were included in the SF12 analysis, and 306 in the quality of life analysis. They found no difference between any of the intervention groups on fatigue or mean 30-day physical and mental components of the SF12 scores, even after adjusting for preoperative score and imbalanced baseline variables. All p-value greater than 0.07 for postoperative fatigue and greater than 0.40 for quality of life. So certainly there's a hint there that there may be a significant trend that's worthy of further pursuit, particularly with the postoperative fatigue impact. Now, their conclusions overall: steroid administration, tight intraoperative glucose control, and light anesthesia do not improve quality of life or postoperative fatigue after major surgery. Now, first thing to note, which we draw our attention to straight away, is apart from the complexity of the trial design, I can understand why it was chosen. Is this that probably could best be regarded as a pilot study, although it's reasonably large with 326 patients. You end up with relatively few per intervention group. And the idea that you'd have a major effect on the significant postoperative outcomes is laudable, but it's unlikely that you'd get anything other than a trend, and you'd be subject to potential errors due to the lack of power, all acknowledged in the paper. Now, the rationale for the study, as I said, is sound. We know that surgery is a pro-inflammatory response. In the paper, this was judged using a surrogate measure, high-sensitivity CRP, which we commonly measure perioperatively or in the critical care unit. It increased roughly 30 times in response to surgery, which has previously been very well described, and changes in high-sensitivity CRP have been associated with numerous different outcome variables. But the increases were similar in the patients who were randomized to tight glucose control and light anesthesia. In other words, it doesn't appear as though light anesthesia or tight glucose control had an anti-inflammatory effect as judged by suppressing rises in high-sensitivity CRP as a surrogate for so-called inflammation. On the other hand, almost like a positive control, although it was an intervention, the high-sensitivity CRP was significantly ameliorated by dexamethasone administration. So as you might expect, steroids given at 14 milligrams intravenously tapered over 3 days had an anti-inflammatory effect as judged by hs-CRP suppression. But the authors also point out that they remain substantial. So in other words, the hs-CRP levels, even though suppressed by the dexamethasone, were still quite high. So they suggest that they failed to block the inflammatory response. Now that's going to be worthy of further pursuit. There's previous trials, there's ongoing trials, there's trials in the pipeline that are going to look at larger doses and different ways of suppressing inflammation. One of the things we always worry about is inflammation is a key component of healing following surgery. That's already been picked off in a number of trials. The question will be, can you give a big enough dose to completely suppress hs-CRP? And if you do, is that the point at which you completely suppress healing processes? So lots more to follow. So I hope you enjoy reading this article, and congratulations to the authors and once again to the Cleveland Clinic for improving our knowledge base.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website epom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. epom.org/meetings.